Hello, listeners, and welcome back to another episode of the Donut of Destiny, the podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Praveen Ranganath, and I'm a radiologist in Dallas, Texas. My co-host is Kashif Shaikh. Kashif, how are you doing, my friend?
Hey, Praveen, doing well. Hello, listeners. My name is Kashif Shaikh, and I'm a cardiologist at UT Knoxville, Tennessee.
Fantastic. Kashif, thank you for joining us. What topic are we going to be discussing today?
Today's episode will focus on finances in cardiac CT.
Excellent. A super important and pragmatic topic for our imagery community out there. And I believe we have an esteemed guest with us as well. Kashif, why don't we introduce our guest?
Yes, Praveen, very excited. Joining us for this conversation is Dr. Ahmad Slim. Dr. Slim is a cardiologist currently practicing in Washington State. He's also a regional chief medical officer of Pulse Heart Institute, a member of SCCT Board of Directors, and well-known leader in cardiac CT advocacy. Dr. Slim, thank you for joining us on the podcast.
Thank you both for having me. I'm excited to chat about it with you guys.
Yeah, Ahmad, I think this should be a great conversation, and it will complement the recent educational offering from the SCCT that you chaired just earlier today, which was the Knowledge Lab webinar on finances in cardiac CT. So to the listeners out there, make sure you check out that free offering from the SCCT after listening to this conversation.
Yes, but guys, while the webinar was certainly very informative, I found a lot of discussion quite technical. I would like to have more informal and perhaps more pragmatic conversation on how these principles can apply to the average imager in clinical practice.
Agreed, Kashif. But before we dive into the meat of that topic, let's learn a bit more about Ahmad and how your interest in cardiac CT advocacy and finances began.
It's kind of interesting because I don't know if you both know, but I was in the service for a while and I did all of my training in the service. So when I was doing fellowship, cardiac CT was still in infancy. When we were still doing cardiac CT with a 16 slice where people would have to hold breath for about 45 seconds to a minute. So we were part of the initial research that was done on that topic, and it became passion as it progressed and it became mainstream, and did a lot of research with Dr. Taylor at the time, Alan Taylor, and Todd Valines. And part of my responsibilities for the Army involved learning about how do we understand the RVU system. The Army had no way of tracking the way the work that we do, our production. And for the region that I was assigned to, we needed to learn how to do that. So I started going to different courses, different training, so I can understand really that concept. And as it solidified, the more you learn about it, the more you realize how much it is a language by itself. It's not something that we're taught in medical school, residency, or fellowship. And the more you understand it, the more you realize the autonomy that we have, the control that we have. Because a lot of times, and I was one of these folks, when I finished, residency, I worked a little bit as an internist, and I always assumed whatever these codes they're telling me about, someone have designed it somewhere in the clouds, and I just have to follow it, not understanding who created it and how it applies to. And as time went on, the more I realized that AMA leads the charge, it's a CPT panel, it's the RUC committees, and all these different committees, the more you realize that we're integral part in a lot of these things, but we just were never educated on it. It wasn't a mainstream topic that we're taught in medical school or even residency.
Great. So I think that leads to our next questions. If we could lay down some basics, in the webinar from today, you highlighted the differences between healthcare policy, coverage, and reimbursement. Could you briefly describe these differences for our audience?
Yeah, I mean, it's a difference in terminology, right? You and I, when we start working as brand new grads, we have no idea what the difference between these different terms. We assume I ordered the right thing based on the right guideline, therefore I should be getting paid for it. And we always assume, well, there's a policy, therefore I should be getting paid for it. Come to discover as time goes on that there's actually a difference. Policy, as I talked about earlier today, is a national policy. Think of it like the guidelines. We all get the guidelines, and it is a guideline, but it's not necessarily something that's mandated to be implemented. So Blue Cross, Blue Shield, or CMS, they can have a policy that's nationwide, but that doesn't mean in my area, in the Pacific Northwest, it's implemented. That's where coverage comes in. For every payer policy, there is an administrative body called for CMS called the MAC. And for the state of Washington, for example, it's Noridian. They determine the coverage, and they could be more restrictive than the policy itself. So the policy can say we will cover cardiac CT for all chest pain patients, but Noridian can decide as a part of their coverage determination that they will only do it, for example, for congenital heart disease or for patients with non diagnostic stress tests. And then they already set the coverage for you. That's what they will pay for. That doesn't mean you can't order the test, but they're not going to pay for it. So, which brings us to reimbursement. That's you getting paid for it. Which, again, the assumption is if there is coverage, it should be reimbursed. I should be paid for it because I followed the rules. Believe it or not, there's nuances, and for it to be paid for. So if I tell you I will pay for non-diagnostic stress tests and I will pay for it for chest pain, and you, for example, put shortness of breath, and that's not something that I cover, even though it's covered for chest pain, you assume they're interchangeable. They might not be, and therefore you're not getting paid for it, even though it's covered. So that's really the difference between policy, coverage, and reimbursement. Try to simplify it as much as I can. Hopefully, it's simplified.
No, Matt, that was perfect. A lot of those in the community that are interfacing with the hospital system or the healthcare system in which they work don't always directly interact with the payers. A little bit of what you were discussing talks about who is doing the reimbursement. Now, generally speaking, I think there's CMS and then private payers. But is that understanding correct? Is there overlap between the two? And also, how do the reimbursements differ between those two entities, CMS versus private payers?
They are interchangeable in a way. They do take clues from each other. Private payers will follow CMS lead for a good portion of it, but sometimes they could be more liberal in their coverage. Believe it or not, it's grassroots operations that makes a difference. So when we look at the state of Washington as opposed to, for example, Texas, you have a little bit more coverage for cardiac CT in Texas than you do in the state of Washington. We have been involved in a lot of the grassroots work to sit with the payers to create what we call local coverage determination. So just by being an active member in the healthcare industry and a representative of a certain entity, you can set up a meeting with the payers to discuss what we call local coverage determination. And with CMS, part of the MAC, you can go for a meeting to be able to expand coverage and payment. For example, just recently, we had a meeting with one of the MACs from CMS to talk about plaque coverage and whether they're going to pay for it, even though it's a Category 3 code or a temporary code. And we were able to get them to pay for it and cover it with a decent amount of coverage and decent payment. But we were prepared. And that's one of the things that I talked about today is don't go solo. Even if you got yourself a meeting with them to talk about local coverage determination, be ready, be prepared. Reach out to the advocacy committee with SCCT. We have a zip drive for almost every topic with clinical trials and research that has probably 20 to 30 articles that can hit the point and will help you create a slide set as well answers the question. Because when you go for a meeting like this, there's always pre-meeting questions that are sent to you because majority of the folks that sit on that panel, they're not even radiologists or cardiologists. They're vaguely familiar with what you're talking about, but for them, it's completely foreign language. So they send you a set of questions to try to understand where the technology applies, what population it applies to, and how cost effective is it. So, we can help you write these questions. There are a lot of us that are expert on the topic that can help you write these answers and will help you set up some slides as well as zip drive. And then you're over ready for that meeting. So you can go in, have a conversation, and walk out of it with the reassurance that the coverage would be comprehensive and the payment would be adequate for the workload that goes in it. Because then when the meeting is done, you can email them the responses, the slide set, as well as zip drive. And this way you're over prepared for it. Does that answer the question?
Yeah, 100%. And I wanted to touch on the topic of how to interface with the local payers a little later in the conversation, but I think this is a perfect place in which to ask this. How do you even go about approaching a payer from a relative novice like me in terms of local coverage and reimbursements? I honestly don't even know where to begin. So, who should I reach out to, or where should I find the people to whom to reach out?
I would start internally. So what happens is a lot of systems that you work in, unless you work in a private practice, which is rare these days, there is someone in your institute or your hospital who handles local coverage determination. There's a group of folks, and their job is to sit down and negotiate contracts for the whole system. So you might be a small piece in it that they haven't thought about, but just I would set up an internal meeting with that person. I would explain to them and be prepared to talk to them as if you're talking to the payer. Because if you can convince that person will be your conduit to set up the meeting with the payers, and they will be the one to facilitate that discussion for you to shine.
That was very well explained, Dr. Slim. So we could get more specific to cardiac CT now. Many of our listeners have heard about the 75571 through 74 CPT codes for cardiac CT. Could you talk about the differences between each of these codes and common situations where each of these codes would apply?
These codes, to start with, are old. They were there from the inception of SCCT and cardiac CT. So I will talk a little bit about the fact that we are working on rewriting them for this upcoming cycle and taking them to the AMA CPT panel to create newer codes that reflect what we do. We have the 75571, which is our calcium score. Then you have your 75572 and 75573, which is your EP planning as well as your congenital heart disease for the patients, and 75574. For all intents and purposes, people usually use 75571 calcium score when they want to order a calcium score, and they use 75574 for everything else, which puts the other two at a disadvantage because they're not being utilized or ordered appropriately by being underutilized. So, one of the efforts that we are working on right now is the application of cardiac CT has changed over the last 20 years. And a good chunk of what we do is structural heart disease as much as evaluation of the coronaries. And the work that goes in structural heart disease is comprehensive and time consuming. So, one of the efforts that we're undertaking along with other societies to include ACR and ACC is revamping the codes and submitting them to the CPT panel. So, we can maintain the calcium score for the coronaries, look at potential evaluation of the calcium score for the valves, adding structural heart disease codes that are not there yet, and expanding on the families for the coronary tree, and adding language in the EP planning to include LA occluder devices and Watchman planning that we've been doing lately. So try to be comprehensive to amount the work that we do to hopefully help us account for the different studies that we do in a simplified way so our users can actually pick the right codes, but in the same process to also reflect the work that we do, because not all cardiac CTs are the same and all the work that goes in it is different.
You mentioned temporary codes earlier in the conversation. Could you elaborate on the idea behind T codes? For example, those used for plaque characterization and how they differ from the cardiac CT codes we were just discussing.
Sure. For our users, because I was one of you, we never understood, we were never taught what is a CPT code, what's an E&M, and what do we do with either one of these. As to simplify it, E&M is your physical exam stuff, and these are the codes that you're taught for the inpatient and the outpatient world. And the CPT code is the code for any procedure that we perform, whether it's reading an EKG or performing cardiac CT. But they don't happen in a void. They take time to be created, and there are stages that we have to follow for them to be created. When a new technology, for example, let's take plaque analysis as a perfect example. When plaque analysis was being developed in the research world, didn't have any codes, and it was new technology. It didn't have even an FDA approval. So when it's being performed, part of that process. It's actually, because it doesn't have any code, we utilize a mechanism called hexpex. And hexpex is a way for us to account for perishables. So your Lexiscan, your adenosine, these are pass-through costs. There's no physician component involved. You get a bill, you pass it on, you get paid for that exact amount. So when a new technology exists and still in the research world, that's the invoice way for us to get paid for it. And these are local coverage determination done case by case by different payers as it's brought in, part of the vendor negotiation. Then the next step is not to go for a CPT 1 code or category 1 code like the ones that we use every day. The next one that we utilize in this scenario is category 3 codes or temporary codes. So once you have FDA approval, once you have enough clinical trials, barely enough, but enough to support its use, we need to track it. We need to be able to tell, well, how much time does a provider need to spend on that study and how much technical component, what equipment goes in it, so on and so forth. So this is when we create a temporary codes. So there's an application created by the societies. SCCT, for example, will take an application called temporary application or category 3 application for plaque analysis. And we'll submit and say, here's examples of sites utilizing the technology. Here's the clinical trials on the technology. And we would like to create a 3-component code. A global code, which covers both the physician and the technical component, and 2 bi-components, professional and technical. One covers your fee, and one covers the technical for the system that you work in. And this would allow us to track the technology over about a year or two, and then we can convert it to category 1 codes. Now, to be able to go from category 3 to category 1 codes, you need 2 major things. You need widespread utilization, and you need at least 5 clinical trials, either randomized clinical trials or meta-analysis. The key word is widespread use, and that's a little bit relative. Because if you're talking about pediatric population, widespread use might be equivalent to 200 patient use. When you're talking about coronary artery disease, now you start talking about 100,000, case use. So because you're talking about millions of patients involved. So that really plays a role when the time comes to apply. When that happens, then we'll take the category 3 code and the data from it, the clinical trials, the widespread utilization, and we create a vendor agnostic general language that describes the procedure in a global component. And then we require a professional and a technical byproducts underneath that global component. You would think we're done, but we're not done. This is just simply setting the language and the mechanism by which we are going to get paid. Then the next step is to go from the CPT panel in the AMA to the RUC panel in the AMA. And CPT stands for Current Procedural Terminology. The RUC panel is even a longer name. It's the Resource-Based Relative Value Scale Update Committee. So you can see why we use the word RUC. And it's also part of the AMA. And the job of that committee is to evaluate the value of that technology. So how much value is there for the technical component, for the technologists, for the equipment, for the gauzes that you use, for the IV tubing, the whole 9 yards, just to account for the technical cost, but also to account for the professional component. So the professional component in there is determined by us, believe it or not. And most of the time, we end up hurting ourselves when we do it. Because what the RUC committee does is sends a survey to random folks about the procedure. Whether they do the procedure or not, it doesn't matter. You could be randomly selected. And you're given a range of different procedures, and you have to account for plaque analysis. Is it less or more than myocardial perfusion imaging time? Is it more or less than cardiac MRI time? And you have to allocate time frame in between. So if you're not familiar with the technology and you allocate less amount of time to it, you just hurt the people that read the technology. Or if you're someone that thinks you're Superman and when everybody else takes 30 minutes to read, cardiac CT, and you say, I read it in 5 minutes, you hurt everybody else. So one of the advice we tell folks is when you get these survey, really take your time. If you can't do it, don't do it. But if you do it with good conscientious understanding that you're talking about your average patient, not your superhuman strength. It's not a macho thing that you have to prove you're amazing. You really are determining our workload, how much time on average it takes us to do this. Because what you put in that survey really determines the recommendation that goes to CMS and the payers that assigns value, RVU, to that work that we do. Does that make sense?
Ahmad, absolutely. I think you've done a super articulate job of bringing us from like the inception of an idea through to how our payers can understand it in the context of the work that we do. But even still, it is a complicated process, and I want to maybe zoom out a little bit and get a bit of a historical perspective on reimbursement specific to cardiac CT. How has that reimbursement been historically, and do you think that the current reimbursements are at par of what it takes to do a cardiac CT, or is there more that needs to be done?
Yeah, we are definitely in a constant state of decline. Understand that there's a concept called budget neutrality. We are the only profession where there is no adjustment for inflation. There's a certain amount of money allocated since the 80s to healthcare budget. And to maintain that budget neutrality, when something else comes in that needs to be paid for, something else has to go down. And there's allocated money in the world of imaging. So as PET CT comes along and is very well reimbursed, guess who takes a hit? Cardiac CT does. And it goes down and down and down with every modality that comes along. And that's why when you look at our language and our procedure code description, it hasn't changed in ages. So it's not really reflecting what we do. So a lot of these newer technology, when they can't come along, we lose in the process and it doesn't account for our work. But there are a lot more reasons for why we're not getting reimbursed. A, we're allocated to the wrong APC in my mind. And APC, and when you look at the outpatient payment service, we are assigned to all CT codes. So this way, we're assumed to be no different than any regular CT for any other organ, where the cost for these is a CT scanner and contrast, and the time of the tech is divided over a whole volume of them done in one day. Versus with cardiac CT, you need specific equipment, you need the right software, the right expert reading them, the medications given, the nursing staff, the monitoring. All of these variables are not accounted for and is not absorbed in when we are bundled in the same APC and then averaged and then multiplied by the data that's generated by something called the charge master. So we end up getting significantly slashed in the process. So over time, the reimbursement for cardiac CT went down from 600 all the way to 170 right now. So one of the things that we're working on at the society level is moving cardiac CT to a different revenue code. So this way the hospitals are able to tag cardiac CT and hopefully cardiac MRI into a different category as other radiology. So they're not average with the other stuff. So we can actually reflect the amount of work that goes to perform these specific studies. And we're working with other societies on that effort right now. We're working on restructuring the codes so they truly reflect what we do. But on top of it, we also have grassroots effort in every state, as well as congressional and senatorial efforts. We have letters that are actually signed, endorsed by senators and congressmen. Last year, we had a letter signed by 15 senator and congressmen that went to CMS, asking them to help us out in evaluating the process. It does put pressure, and it would help us when the time comes to move things to different APC. It might not work effectively right there on the spot, but just one added pressure point to ensure that the patient gets the study. Because if you have a study that costs operationally 300 to 400 to do, and you're getting reimbursed 170, you just disincentivize the performance of that test, even though it's superior to SPECT that's getting reimbursed at $1,300 a study to cover the cost of operation.
Great. Ahmed, you mentioned nukes and MRI. So is that 170 versus 1300 are those like technical and professional fees? And how does CT compare to PET CT, for example, or stress echo?
So when you do a stress echo, you get reimbursed around $500. When you do a SPECT, it's about $1,300. When you do PET CT, it's about $2,000. And when you do a cardiac CT, it's about $178. So a huge discrepancy
Yeah.
in payment. And that's, again, goes back to the group that is bundled in. Stress echo, SPECT, PET CT, they all fall under the same category. When cardiac CT falls under regular CT, so it's getting averaged with CT chest, it's getting averaged with CT angio, it's getting averaged. So every CT organ that's being done in that charge master.
And a lot of our listeners work in either private groups or academic centers where much of this discussion on the individual or local basis comes down to bottom line. And a lot of these facilities are super complex and quite heterogeneous, right? You have your rural hospitals and they may only do a few straightforward CTs. You have your large academic centers and they do high volumes of super complex cases. With that in mind, particularly about bottom line in these different institutions, could you talk to us about like a rough idea for how one can model profitability of a cardiac CT program in the context of how heterogeneous health systems can be?
So it all depends on the revenue cycle that you're working within. So a perfect example, if you have a system that does TAVR and mitral clipping and valve, so when you're doing the CT TAVRs or structural heart disease CTs, they're profitable, not necessarily with the margin that they generate, is they're profitable within the margin of the procedures that they generate. And the same thing applies for coronary CTs if they're identified in the right population. So in the sense of, if I work in a hospital and if you look at the chest pain DRG doesn't pay that much. It's about $3,000. So if you have someone coming in and you're getting paid $3,000 for that observation, if you do myocardial perfusion imaging and it's $1,400 cost as compared to $180 cost, and getting the patient out in a much faster time frame, now you go from a DRG where you're actually losing money to a DRG where you're actually making ends meet. So from hospital perspective, integrating CT as part of a comprehensive model where it's cost effective is ideal, is perfect, versus utilizing it across the board, especially in smaller hospitals. It might not be as cost effective if it's not integrated within certain pathways. So for my system, we just integrated the chest pain care pathway. And part of that chest pain care pathway is heavy use of cardiac CT in the chest pain population under 65, with the goal of trying to bring them in, use high sensitivity troponin. If it's negative, cardiac CT. If it's negative, go home. And you're still averaging, less than 3 hours in the process. I had a publication from my time when I was in the Army where we specifically looked at that in a closed referral system, and it led to $600,000 cost effectiveness within a span of 6 months.
That sounds encouraging. So let's shift gears as we come to close off our conversation. What would you recommend to our listeners out there that have interest in cardiac CT finances and advocacy?
I would say reach out to SCCT Advocacy. It's one of the few advocacy places where we're actually always recruiting folks to help us out. Because one of the things that Makrabat, the chair, and myself as a prior chair, we've always agreed on, grassroots makes a big difference. And we have a lot of mentors that have the time and willing to teach and help you, because it's a language by itself. And the more we can part that knowledge and teach folks nationwide on how to do it, the pressure points, and how to utilize that language, the better off cardiac CT will be, because it is the better test. I do sound that I am biased, but it is the better test for our patients. And we just need to make sure that if there's someone willing and have the time to volunteer, we will take advantage of that time and we will teach them in the process about the finances of cardiac CT and finances of cardiac imaging altogether.
Ahmad, you have been eloquent as always. Thank you so much for sharing your expertise with us on the show. Really, really appreciate it.
It's been my pleasure. Thank you for having me.
Thank you. Thank you so much, Ahmad.
Anytime.
Perfect. Thank you. And the listeners out there, as always, thank you for tuning in. Be sure to check out that SCCT Knowledge Lab webinar we were referring to that touches on a bunch of these topics that we just discussed in this conversation. If you like what you hear from us on the show, please take the time to rate, review, and subscribe to us. It really makes a difference. Once again, this is the Donut of Destiny. Cheers.